My name's Anna Starling and I'm a Policy Fellow at the Health Foundation, and today I'm going to talk about the Multispecialty Community Provider Framework. We all know that health services have to change to meet the challenges of an ageing population and more people living with long-term conditions. That includes breaking down the historical divides between primary, community, mental health, acute and social services, and bringing specialised care closer to home. That's why the multi-specialty community provider model is important, and why the Health Foundation was encouraged by the publication of the MCP Framework earlier this summer. The framework does recognise, though, that an MCP can't simply be willed into being because of the complexity and scale of the changes required, and that's an important point.
Well, an MCP is a provider that brings together primary care services, community services, social care in a transformed way, and it's about bringing those services together on a population basis, so that in the case of Dudley, the way we look at this, it's about bringing teams of people together for a shared responsibility for the same shared population. For us, it starts with the patient registered with a practice, and we've organised our model of care around that basis, because in the NHS everyone is registered with a GP, and they look to the GP as the lead coordinator for care in the community. And we've designed the services around the themes that the population are looking for from us, which is about better access to services through their GP initially, or their GP services associated with that. It's about better continuity of care around long-term conditions management, and it's also about better coordination of care, particularly for those people with complex needs. And all of that starts with a patient registered with a practice, which is why we've developed an MCP model which has general practice at the heart of it.
Looking at the multi-specialty community provider from a patient perspective, I would hope there will be advantages in the future, so that with all of those organisations, both from the NHS and the council, together with voluntary organisations all working together, that hopefully if I ever need support as a patient with long-term conditions, that whoever I talk to first, whether that's a voluntary sector group or it might be my GP more realistically, that I'll only have to tell my story once, as all the records will be shared. So if I've had x-rays or scans, they'll be able to be accessed by anybody. I'll also have my own records because I want to take responsibility for my own health, so that I'm as fully informed as possible. So I see the MCPs as really pioneering that way, really getting organisations to really work together, so that I won't get what sometimes happens, oh well, we can't do that, you'll have to go back to your GP again and get referred elsewhere, but that somebody will link me with something or help me access that from elsewhere. The other thing that I think is different about the MCPs and the other vanguards is the desire to really work with patients, people in their communities at a very early stage, to have them help inform what is decided, what does get changed, how things work. I know that as somebody with quite a lot of lived experience now of different conditions, that I see things differently as a patient. And I'd like to share what I see with the people who are designing or changing how things might be. So I think it's really important to engage your patients, public and the communities you serve at the very earliest opportunity in a really meaningful way. And this is different to just ordinary consultation or ordinary engagement. And I think whether you call it co-design or co-production, it really is the way to go, because it really does make a difference. I do some work with the Coalition for Collaborative Care and sit on the People and Communities Board, where working obviously with the voluntary sector and in partnership with patients and the public is absolutely crucial and will help make those shifts, both for efficiencies, so that things aren't provided which aren't necessary or duplicate, but also to get that quality right. so that it's really about what matters to me in my life. And to help that, there is a model that's been developed by the Coalition for Collaborative Care and the NHS, a very simple one side of A4, looking at the values and principles. So for any, whether that's a group, organisation, or for parents or for patients to share as well, that can helpfully be a starting point. I would hope that in the future, all of the work that's being done will mean that there will be better quality of support, whether that's in organisations or from groups, and that it will be not only integrated but it will be coordinated as well, and really help me in what matters to me.
Hello, my name is Louise Watson and I'm the Multispecialty Community Provider National Lead within the New Care Models programme. I'm here to talk to you today about the Multispecialty Community Provider Care Model and what it means to you and how you might be able to develop within your local community. The model itself is a population health-based model. That means the focus of the model is the patient and how the patient interacts with their local community. What I mean by that is that the whole model is focused on the neighbourhood and how the patient works, lives and actually gains their health and social care provision within that neighbourhood. The focal point of the model is the GP and their GP registered list, and therefore the model is built out from the GP into the neighbourhood and then into any hospital or community services that are then required to support the provision of healthcare for that patient. In terms of things that we have learned along the way in the 18 months that we have been working with the Vanguard sites and with the New Care Models programme, there are three things that I would like to point out to you. The first being that it is essential that the partnerships are aligned within any community. What I mean by that is that health and social care partners and organisations have the same understanding of what they are trying to do in terms of the development of a care model, and that they are aligned within their strategic intent and that they have a plan which articulates this over a period or course of 1 to 2 years. The second aspect that I'd want to draw your attention to is actually clarity around the care model itself. It is essential that all partners understand how they're going to develop the care model, what the care model looks like, and also how that will benefit their patients and how they are going to involve their patients and their community in the development of that care model. I would recommend you use the framework and also use those Vanguards and New Care Models teams who have developed the programme initially to support you in doing this. The final aspect that I would commend to you is the development of a robust programme office and programme management functionality. This will keep track of where you are going, will enable you to understand the risks and challenges that you face in developing the care model, and also enable you to understand the return on investment that you will need to ensure that the care model is safe, efficient, effective and of a high quality for your population. Thank you.
So, my name is Michael Lorry. I'm an analyst in NHS England and I'm overseeing the evaluation of the New Care Models programme. So I've been asked to talk about what a logic model is to begin with. Well, a logic model, it comes from the field of programme evaluation, policy and programme evaluation. It's a methodological tool that most evaluations will use. The government sort of recommends their use when one comes to evaluate a piece of work you're doing. Logic models are based on the premise that at their heart every programme or policy or intervention is a theory of change. It's a theory of doing things better or addressing a social challenge or a social ill. And a logic model is an attempt to encapsulate this theory of change into a diagram, into a single diagram. It links the inputs to that programme, so the resourcing or the skills that have maybe gone into it, with the activities that are being funded, what is the programme actually doing? Is it a training programme? Is it, as with the new care models, is it trying to bring in population health approaches with the end benefit that those programmes deliver? So it links those three concepts together inside one diagram, which then has a range of other uses thereafter. If you get the right people around the table for your programme at the right time, early in the programme when your care model's at a sort of nascent stage in its development, if you get analysts, policy people, programme leads, of course clinical staff around the table to think through the detail of what how you might go from A to B. We found in the Vanguard programme, but that had massive benefit for the programme itself. So yeah, there's definitely benefit to the end product, but we really think there's benefit to the process of developing the logic model as well. Okay, so where can you go to produce one of these? Well, from the centre, from us, there are, we've learned things about producing logic models through the Vanguard programme. So the first place to look is the Vanguard logic models, and we can make sure that they're easily accessible. We've learned about the process as well, and there's a learning paper produced there. But that's only going to take you so far. I think what I'd advise is to start thinking about evaluation and analysis of your programme from the beginning. How are you going to measure, in effect, if what you're proposing has worked? So to do, you might want to find out people who can do evaluations for you. And the obvious place to start are your local universities. But we know that the commissioning support units can help with this too. Academic health science networks, and there's also consulting firms who specialise in this sort of work too. So there's plenty of expertise out there who can help you to begin with.
Well, if you take a patient with complex needs, they don't want a siloed response. They want a response that deals with their whole needs. So in Dudley and in many MCPs, we've developed multidisciplinary teams based in the community, which is coordinated by the GP, but includes a social worker, a mental health worker, a district nurse, a pharmacist, also particularly important links to the voluntary sector. And what those teams do is they work as one for a shared group of patients to take a shared responsibility. And because they're working as one team, they're able to provide a holistic response that meets their whole needs as a person, again, rather than an individual siloed response. Well, I think if you look at the last decade and a half, what we saw was a transformation of secondary care, which really delivered phenomenal improvements in, for example, waiting times, but also in terms of outcomes. And what the MCP is about is the transformation of the other half of the system. In the past, we've had all those services separated, disconnected, not as one, and the MCP brings together all of those disconnected services to create a transformed primary and community service.
Model is a population health-based health and social care model. What we talk about within this model is 4 different aspects. The first aspect is the extensivist aspect of the model. This deals with the most high-intensity users of health and care services, and we look at this through patient segmentation and through risk stratification. It usually applies to about the top 2 or 3% of the population, and specific health and care services will be put in place for that individual related to their specific health and care needs. The second aspect of the model is the enhanced and extended primary and community care services. What we mean by this is that services will be in place within the community and the neighbourhood where that patient lives to look after them, be they having long-term conditions or a condition that is exacerbated through no fault of their own. This means that care will be wrapped around the patient, and that multidisciplinary teams of professionals such as pharmacists, social care workers, nurses and community nurses will all support that patient with their care needs as and when required. The patient will have a care plan which will ensure that they understand and they own their own care needs alongside the professional that is working with them. The third aspect of the model is responsive and accessible urgent care, built up through a network of urgent care services within the community that are in line with the patient's needs. Finally, there is the whole population health management aspect of the model. This is very much about the community and the individual being able to look after themselves through self-care management, through community support and through community activation. And what we mean by that is that the social interaction of people within their own community is vital to their health and well-being, and the model itself promotes this community engagement and activation as a fundamental part of what it means to be sitting and living within a multi-specialty community provider model. The multi-specialty community provider framework outlines the model of care, so the clinical model of care that we are talking about today. It also outlines the possible contractual arrangements that could be put in place to provide such a model. It is a very useful document to use as a reference point for anyone thinking of developing such a model to support their local community.
So my name's Ed Waller. I'm the head of the MCP contract development team in NHS England. The first question, I guess, if everyone is, why have a new MCP contract? Essentially, the MCP contract isn't an end in itself. It is the thing that will sit behind the care model and help to ensure that all the care model's benefits are realised. And in particular, the thing it will allow people to do is deploy money and people in exactly the way they need to make the care model work. Why does it have to be different from contracts that have gone before? So the MCP contract isn't a contract between a commissioner and a individual GP practice or clinician. It is a contract between an organisation holding the contract to deliver the MCP care model and its commissioners. And that means that there are a number of different ways that GPs and other clinicians could relate to that MCP, and I'll come to that in a minute. We've described 3 different ways of contracting for an MCP. One of those, an alliance model, allows existing providers to keep their contracts as they stand and overlays an alliance agreement over the top, describing how the providers will work together to deliver the MCP care model. And as you start to get more integrated in the contracting sense, a new contract will be required to replace those commissioning arrangements. So we've described 2 ways that might happen. At one end of the spectrum, in fully integrated form, a new single contract that replaces all the commissioning arrangements with existing providers and covers the whole purview of the MCP service scope, including core primary care. And where GPs don't want to give up current GMS contracts, an option for a partially integrated MCP contract, which allows GPs to retain their current primary care contracts and for another contract to hold the rest of the MCP service scope.
Okay, cool. Okay.
So some of the learning from our existing vanguards is that the relationships in the local area are really important, and it's likely to be that MCPs will come to life as a result of strong relationships between a number of partners in the local area. And some of our vanguards are thinking about moving all the way to a partially or fully integrated MCP in one go. Others are thinking that they might want to take the step of going through an alliance phase before they do that. And as our early vanguards, take the steps that they do to bring an MCP to life, we are going to record how they've done that so that those that follow can share in the learning. We have a national team who are here to help if you want to ask any questions about how procurement, commissioning and contracting will work in an MCP, and we are happy for you to get in touch if you'd like one of those discussions.
Hello, I'm Peter Bennett, a GP in St Anne's-on-Sea in Lancashire, and I'm involved in the Farnham CCG as a clinical lead for long-term conditions, and have been involved in the new models of care over the last 2 to 3 years.
Hi, I'm Felicity Guest. I'm a GP in Thornton Cleveland in Lancashire, and I'm one of the clinical leads at the CCG at Farnham with the responsibility for the vanguard and innovation.
Since the CCG started, we've been quite keen to get involved in some innovative work, relying in many cases on our GP population to really activate them, and I think we realise that they are an undervalued resource, and from an early stage we were keen to get them involved in the CCG, in the Council of Members. I think you found when you joined us that this was one of the key strengths of the way we were working, didn't you, Felicity?
Yeah, absolutely. I think it's one of the big strengths of the CCG, and it's why we've been able to drive on and be successful with the Vanguard programme as well as other things. And that's around a lot of strong clinical leadership, both within the CCG with the official roles, but also looking at good relationships through the wider GP community. And it just shows that putting in that effort at the start to build those strong relationships, it means that you can deliver on things later on.
One of the early ideas that we had was to divide our population into neighbourhoods, and I think this was built on ideas that other people had, and what I felt was good about it is that it seemed to resonate well with a number of our other stakeholders and partners, social services, the local council and people like that. How did you feel about it, Felicity?
Yeah, I think it's worked really well. It's given local GPs a bit more opportunity for innovation, looking at their local priorities and feeling like they're having more of a say. And it's resulted in a lot of really exciting projects that we sort of got up off the ground, really. So one great example is we have a care home project in one of the neighbourhoods, and similar ones coming on stream in other neighbourhoods, which were already having big impacts in terms of reducing hospital admissions and improving care, reducing demands on general practice.
I'm from the generation where GPs virtually never spoke to each other, certainly never spoke to the neighbouring practice, and it was very difficult to get any sort of communication or agreement going. How have you felt that things have changed?
I think enormously. So over the last couple of years, the sort of CCG approach in the neighbourhoods have sort of incentivised us to all sit down together and spend time together. And now the approach is we're all looking at referral rates together, and it's a real impetus to drive good practice forward, really. And looking to the future in terms of our MCP development for next year, it's going to be really key. Those relationships are very key in terms of people working together much more closely, trusting one another.
I think you make a very good point there, Felicity. I think developing the trust, recognising that we have a shared culture, I think has been an important strength of ours within the CCG GP membership. I think it's also helped us to develop relationships with other stakeholders. I mean, my view is that there are sort of people in social services, in the local councils, in the housing, in the police force, who can understand what we're trying to do if we go out there and sort of sell it to them, and they've been very keen to come on board. It's been important to get that trust and culture early, before getting too involved in organisational forms.
Absolutely, and I think those relationships have informed all the design of our care models. So our extensive care service has been, a big part, a big driver for us, and has been up and running for over a year. showing great results already, and a big part of that has been this sort of holistic approach, looking at relationships and working more effectively with non-health services.
Yes, the extensive care service, I think, again, was one of our successes, built by very close working with the acute trust.
The beauty of extensive care is this sort of mixed health and wellbeing approach, and the care coordinators and the wellbeing support workers really pushing people forward and activating them and moving them on. And one of the things we've found actually is that people aren't staying in that service for quite as long as we'd expected, and that's because they're being well activated. And at the moment we're not seeing huge rates of re-referral at all, are we?
No. I think the figures are certainly showing that we're getting 19-20% reduction in our non-elective admissions, and we're seeing probably an even more significant reduction in elective referrals, which I think has been quite interesting. Many of us can talk the talk about a holistic approach and working together in MDTs and so forth, but actually organising it can be more of a challenge than we may think.
I think part of the key is being moving away from that traditional medical model of the GP can do everything better than anyone else can, simply because they've got the most letters after their name. That's simply not the case. Even if I had the time, I don't know about all the 50 voluntary organisations in our local area that our care coordinators do. I'm not the right person to be signposting there. I'm not the right person to be sort of having the detailed discussions about somebody's diet and diabetes, because that's not what we're here for. And I think that's a message that with some of our colleagues took a while to get through, but I really think that we've succeeded in promoting that amongst the wider GP population.
The way the MCP model has been described in the framework, I think is quite exciting. I just wonder what you feel about it.
Well, I think the future of general practice is all about closer working with partners, and we've talked about how we've got good relationships locally, and that's going to stand us in good stead going forward. I think that we know there are workforce challenges, and we know there's no alternative but to do things differently, but we don't necessarily need to see that as a negative. We can see that as a positive going forward. And I think that's what the MCP allows us to do, to have a strong community care and primary care voice in delivering services and in designing services in the future, and working sort of more collaboratively with provider colleagues. So at the moment we're in silos, aren't we?
Yeah.
But the idea of working with the community trust, for example, designing, working together without all these sort of gaps and communication problems that we have at the moment. I think the MCP is really the vehicle for driving that forward.
Yes, I certainly think community provider, I think, the exciting thing. There's always historically been that sort of division between primary and secondary care, and I think our GP workforce will be very interested in sort of having a bit more of a handle on the breadth of the provision that we could do. That I feel there's a lot of untapped potential within the GP workforce, and I think one way of keeping them in the job and certainly encouraging them into the job is to be able to broaden their portfolio, broaden their way of working, and their sense of having some sort of control of what they're doing.
And I think equally with secondary care colleagues, we see this artificial split, but I think our experience in terms of trying to design an integrated diabetes service as well as the extensive care has been that actually there are consultants who are really keen to do things differently, work more in the community, work more with us. And I think when you get those groups of clinicians sitting down in a room together, we realise how much we have in common, and how we can design services around the patient which are going to work much more effectively for the population's future needs.
To succeed, it is essential that teams are supported to build their improvement and learning skills. It will also require creating cultures of learning that allow staff to challenge assumptions and innovate. This is something we've seen in the improvement projects the Health Foundation sponsors around the country. As the programme progresses, it will be crucial to encourage vanguards to share their learning about successes and failures. It is in this way that communities can be supported to change the way they deliver care for the future.